So let me first introduce the panel briefly. Melissa Thompson is after you participated in the financial crash, right? You were part of that.
I was a casualty of the financial crash.
Doing penance for her participation in creating the financial crash, she was on Wall Street like some of the other smart IT people here. She's now bringing those skills to healthcare and is the pioneer of a terrific telemedicine, consult with a doctor anytime you want, a psychologist anytime you want, and she'll describe it to you more, but off of a tablet. Wesley is a leader, a thought leader in Wesley is a thought leader of the Knowledge Network, as those of you who have been active in the Knowledge Network know, but he is from Denver, a licensed clinical psychologist, IT leader, and very, very knowledgeable guy about how life really works in this field. Deb Scharf has been studying, is also a clinical psychologist, I believe, and has been studying with SAMHSA money all of these grants to integrate physical health with mental health around the country. So she is just coming off of real world, go see what happens when we start talking about mental health without walls. But let me start with a little bit of maybe what that might look like. Do we have these? Oh, they weren't. Okay, never mind. So I had some slides, but I don't have slides. So let me try a little bit of an introduction off the cuff at the beginning, and then we'll just start having an open discussion. One of the things we know is that for people to feel really well and vital is what they want. And that's what we want for them. We don't want them to be not sick. We don't want them to be alive. We want them to be vital. We want them to be happy. We want them to have energy and capacity. So how do they do that? Well, obviously, they need physical health care, right? That'll solve, well, no, it won't. That isn't enough. Well, they need to be fully nourished. Yeah, maybe, although none of us ever talk about that much within mental health or physical health, but they need nourishment. And we have this horrible world malnutrition problem of hidden hunger affecting a couple of billion people. And yes, mental health is really important. Exercise is important. There's a bunch of things that are really important. And if we really were patient-centered, we would be focused on all of those. And we would have a holistic approach to addressing how we can give people or help people. You can't give it to them, how we can help people achieve vitality. But we operate in silos. All over the world, we operate in silos. And we operate on a facilities-based, expert-based, come to me, sit down with me, and I will fix you system that, as was said earlier, is incidental. It is, when problems arise, it's low volume, high cost for the individual, and it's terribly ineffectual. I mean, it's not like we, contrary to what some people in Washington, where I live, seem to think these days, we actually don't have a very good health system. We have about the worst health system in the developed world, certainly the most expensive one, and yet we're not achieving very good results. So what would a system without walls look like? Well, first, it would be focused on people. It would be focused on the person. It would be second, it would be outcome-oriented. We wouldn't spend much time worrying about how many hours we spend. So we were worried about what achieves vitality. Third, it would be evidence-driven. I mean, and that evidence would not be from one field. It would be from all of these different fields. We were talking, the last speakers were talking about probability, about social scientists. What Casey didn't say in his excellent remarks, and the speaker before him, is that they're challenging the catechism. I mean, if you get up and say, well, you know, life is more complicated than your randomized control studies. We're out of the world of one molecule will kill another molecule. We need to actually study the world. And the world has nutrition, and nutrition is much more complicated than the 5 big elements that public health people talk about. And by the way, there's this whole microbiome thing going on behind nutrition once you figure out nutrition. And it's got physical health, and it's got mental health, and it's got environmental health. And it's got your social relationships. I mean, we are complicated people, and achieving vitality is complicated, and anybody who thinks we can reduce that to a set of equations that prove what causes what is nuts. But those kinds of probabilistic studies of looking at what's, we are the results of complex adaptive systems. So let's just start doing the research on complex adaptive systems. And the good news is that thanks to these devices that we're all carrying around and a whole lot of others that are coming with them, we're going to have enormous amounts of data. And thanks to the work of people like the previous speakers, we have the ability to analyze it. And we have the ability to fix it and improve it and learn over time. And that gives us the ability to bring down costs in the same way that it's come down in other industries. So this is a very, very exciting time to be in our fields. It's a time I spend most of my time focused on how we bring vitality to people who live in places without electricity. But they have a cell phone. So we need models of this that are incredibly cheap. And if we can get them there, we can have them here. And they can be effective. And we can do things like gather data from multiple sources. And by the way, back to the last question that I think somebody posed, all the data doesn't have to enter the person's file from a person-to-person interview in the office of the psychologist. I mean, we can count on people to put most of their data in. So anyway, there are great possibilities here in front of us, and I think one of the things that we tend to think about is we tend to think incrementally, and so hopefully from this panel and the discussion, we can kind of jump forward and think about what is the big leap that we can do, because frankly, having spent most of my more recent career dealing with the established medical profession, physical medical profession, I think if there is an organized healthcare profession that can help lead us there, it's probably yours, because they are much too inflexible in their highly organized states. Even though I love Sinai Hospital, it's a wonderful place. I don't think that's where the revolution's coming from. But anyway, let me turn to the panel and start with Melissa and ask them to take a minute or two and address what they see as their vision for where health is going. And then we'll just kind of go back and forth for a while and then bring you into the conversation.
Thank you so much. And thank you, everyone. I'm pretty blown away by the work that everyone's doing. And I can't wait until we can put this into practice, because my vision when I started Talk Session was to create a system that increases access and provides relevancy. The access issue is at a very basic level, an enormous one, and we're talking about these really exciting things, but if we think, take a step back, people just aren't getting care at all. So we started by trying to build that simple solution. So 90 million people are underserved by mental health care, but everyone has cell phones. So we built this platform. It has one button, and it says request a session. You log in, and that's one button. And a physician who's in that network, let's say it's a community clinic network, will have a queue, and we'll see the patient requests. The platform is available on any device, anywhere, anytime, and it costs about 10% of the cost of current telemedicine solutions. So to Jeff's point, the cost of technology is going down at such a rapid pace, and we need to take advantage of it. And a lot of the systems that are in place have taken so long to become implemented and people to become used to it, that I think besides regulation, practice, it would be beneficial to try to keep up with technology if possible. The second layer is relevance. So this is basically advanced walkie-talkie. You press a button, someone picks it up. But wouldn't it be great if I had a certain condition and the best person possible for me was available somewhere that was in Alaska, for example. I can stand on the border and 1,474 miles away, I can legally talk to a doctor on the other side of the state of Alaska and get reimbursed for it through telemedicine. So that's extremely powerful. So we can add all of these elements of artificial intelligence. And I'm incredibly excited. In fact, I wear about 30 sensors, and it's a sample set of one, but I run experiments on what makes good therapy good, or what elements and inputs can we use to make our lives better and to make better relative matches. And if we can create this kind of data mashup of clinical, diagnostic, and personality matches between patients and providers, and then layer in EHR systems and self-input data, you can create really, really powerful matches that can be accessed very easily, seamlessly, and in an elegant fashion. So,
thank you. Wes?
So first of all, I'd like to say, this has been a very exciting and well put together afternoon. Thank you, April, and everyone else at CRI for putting this agenda together. It's been very thought-provoking, and it really, I think, for me, emphasizes the gap between sort of the vision and the practice that we have right now, right? One of the big projects that we're doing at the Mental Health Center of Denver is looking at and understanding recovery from severe and persistent mental illness, and looking at it not just in terms of symptoms of schizophrenia or bipolar disorder, but really looking at the whole picture, the whole person, how their sort of quality of life is in terms of housing, education, and active growth, employment, social supports and connectedness, in addition to things like symptom interference, and thinking about how all those different moving parts work, and how to sort of align treatment so that you can focus on the current sort of biggest drivers at the time, right? And we started out maybe 10 years ago thinking that these things were important, and we're not able to measure them. We're not able to measure sort of our current state, much less any progress we make on them in a sort of a reliable way. And we've developed what we think are sort of effective means of starting to measure those outcomes. And more recently, I've become engaged in bringing that back into the clinical practice, right? So instead of just looking at outcome trends overall as an organization, how are we doing? Bringing it back into the clinical session so that the psychiatrist or case manager has an actual conversation with the consumer at the point of service. You fill out the survey, you take a look, how am I doing? How am I doing today versus 3 months ago versus 6 months ago? What are the drivers there, and how do I focus those interactions? It really was, it resonated with me, Casey's point of, this is the person making that turn on the street and, looking and trying to sort of adjust course. I think the frustrating part there is that so in a car, you can turn the wheel left or right, and you can step on the accelerator or the brake, right? There's like 4 inputs, right? In therapy, I think about what it's like to be in a session with someone and all the little decisions that are going on in your head as you're tracking the conversation and trying to decide, what do I say next? Do I break from the treatment protocol? Is this even the right thing to be doing right now? Is this an emergency? So that's the vision, right? Is to be able to bring sort of this analytics in and focus, I think, on what we believe really matters in terms of treatment. And unfortunately, I think it's frustrating, because part of my job is that, but another part is sort of reporting and, electronic health record development and health IT, and I spend a lot of my time, sort of an alarming amount of my time, thinking about questions like, who's done their progress notes? you know. So I mean, it's not particularly interesting stuff, but it needs to happen to sort of run the business. And I take a look at the sort of big sexy stuff that we get to talk about here this afternoon, and think like, can we bring that into the clinics, or better yet, out into the streets? I mean, realistically, in Denver we serve people who have no electricity, they're homeless, right? But they do have smartphones, and what can we do with that? How can we bring that into treatment, in the next 12 months, rather than waiting until we've figured out the biome?
Integration Grants Program, which has been mentioned a couple of times. It's now 100 programs strong across the country, and basically grantees, and I know there are some of you in the room, have received approximately $2 million over 4 years to bring primary care services into community behavioral health care settings. And grantees of this program had a number of required features, things they were supposed to do, but none of them were specifically primary care. The grants were intended to support infrastructure change and development, and support services for which there weren't readily available billing mechanisms. So things like wellness services, and to develop registries in HIT, to get peers involved in those kinds of things and programs. So to do some registry and tracking, and so to expand the sort of day-to-day routines of behavioral health providers to really include more whole health and primary care and wellness services. So what is exciting about that program is that really grantees could do whatever it took to get the job done. And so along the way, at least what we've learned from the evaluation is that programs have been really successful in developing a rich array of services. So different programs have different foci. They're interested in smoking, or they're interested in weight management, or they've become really invested in cardiovascular health and doing wellness fairs and having mobile vans and delivering care with, for example, providers who speak sign language and do a variety of things. So there's a really rich array of approaches across the United States to bringing down walls and enabling better access to care for adults with serious mental illness, primary care access. At the same time, there have been a lot of challenges, and despite the richness and uniqueness of the programs out there, some of the things we found is that many of the barriers are shared. So barriers around financing and sustainability, barriers around consumer enrollment, even though programs have done a great job of advertising, putting together wonderful packages of services. Many times they fell short of enrollment expectations or targets, so they opened the doors and waited for people to come, and they kind of trickled in instead of sort of rushing in for services. So on the one hand, while we as providers, policymakers may see the importance of making sure that primary care services are available to folks, and that they're getting preventive services instead of going to emergency departments, and being hospitalized for preventive health conditions, sometimes there needs to be some intermediate PR, if you will, to make sure that folks understand the value of coming for preventive services, and the value of not going to the ER, where services are available all the time. You could just go. So that's convenient, whereas you might have to wait weeks to see a doctor. So there's work to be done to communicate, what we as sort of on the academics or policy end of things believe is important and right, to make sure that, again, it's person-centered, and that consumers see the value and appreciate the services that we're offering. So I can certainly talk more about the ways in which some of these programs have succeeded, the challenges that they had, certainly licensing and sort of expanding the role of different providers. So if you are a behavioral health person, you might not know enough about diabetes yourself to be able to ask those questions, to prompt your consumers to be thinking about their own health in those regards, and then to help connect them to the right services, because you might not even know that a person with diabetes needs a foot exam. So there's lots of room for growth and improvement, and at the same time, we did see some positive physical health outcomes from the trial. So there's also capacity for community behavioral health centers to really be an engine for promoting physical health among consumers, and I'm glad to talk some more about that.
Thank you. There are a couple people you don't know that I just wanted to mention to you because I think they're going to be part of this revolution. One is named Tim Bickmore, and if you haven't run into Tim, I encourage you to. He is Mr. Avatar. He has developed highly successful video avatars that are currently being rolled into hospital rooms when you're being discharged. Hospitals were finding they had a huge problem of non-compliance with discharge instructions for a whole variety of reasons that all of us can imagine. And so his team studied the really good nurses and really good docs who did discharge instructions. Really good being defined as the person actually followed the instructions as opposed to a nice person. And built this avatar that rolls in on a computer and it tells you what to do, it tells you what the instructions are, and you have the conversation with it by pushing buttons as to whether you understand or not, or you have a question about it, and the avatar is on the screen, talks to you. And afterwards they polled the people as to what they liked best, and 10% went with the live doctor or nurse, 74% went with the avatar. So I think he's doing this with, he has an avatar named Laura who's working on antipsychotic meds, getting people to work on compliance on that. So I think you're going to see a lot more of that in the future. Not that we're going to replace all of the psychologists with avatars, but I think you're going to see it. But since we can't afford to have psychologists everywhere they need to be, we're going to need information systems that do that kind of thing. Second one is a guy named Buddy Ratner, who is a genius at the University of Washington in surface analysis. He's a physicist, a biophysicist, and he uses mini mass spectrometers like they have on the Mars rover that break up rocks and shoot ions at the rocks and say, oh, this rock is made up of the following things. And he's using that now for nutritional analysis. And what you're going to see in about 4 or 5 years when Samsung gets its hands on this technology is that your cell phone will include a thing you point at your skin and will give you a nutritional analysis. Not your hemoglobin level, because that's just one, but the full spectrum of your nutrition, which will allow you get on the scales in the morning and it tells you how you're doing on weight. And from that you can calculate BMI, which by the way from a nutritional spectrum is a useless measurement and you should not be using it. It tells you whether somebody's overweight or not, fine. But we'll have all this data, all this complicated data that then people like Casey will turn into forms for us. The third one is a set of people whose names I've met a few of them who have created really effective CBT therapies on smartphones. The problem with them, and people like my colleague here on the right, is that those are innovations that lack a system. So you need to have a system, kind of a transformed system to take advantage of these things, and a piece of that needs to be the research base. So I want to announce a project that all of you can participate in because Centerstone, CRI is actually leading it with NIMH. And it will happen, have a big meeting at the mHealth Summit in December, and that is to develop the research system of the future that will grab these kinds of ideas and build the kind of spiral development system Casey was describing underneath the behavioral health system of the future. And we're having a workshop to try to bring together industry and practitioners and researchers and academicians in a conversation that will start next week with a draft paper going around and then meet in person on that. So anyway, those are some tidbits that were in the slides that I forgot to mention at the beginning because I lost my slides. So if we move to outside of the clinic, so Wes, you see yourself as a base and do the stuff you're doing within the walls better because you'll have more evidence, and so that's fine. What are you going to do if you imagine a pyramid and you're the top of the pyramid? What are you going to do about the base of the pyramid? All the people who are not coming into your walls, some of whom you may want to get into your walls. You want to connect it to what you're doing. You'll want a bunch of apps downloaded from iTunes and independent of you. What are you going to be doing out there?
Yeah, well, we're definitely going to work on multiple angles on this, and certainly one of the pieces is building a bigger pyramid, right, where we can see more of the folks, because currently, I think, for every person that we admit, we turn someone else away who is equally qualified for our services, right, just based on capacity to deliver treatment. And I think, we've talked about moving towards doing more prevention and outreach work and sort of nipping things in the bud earlier. Really the big growth area for us is working with children and families in the Denver metro area rather than waiting until someone is already homeless. But the other piece there, I think, is, sort of where you're getting at with the, being able to leverage technology, being able to leverage consumer-driven treatments and interventions, and I think there's a lot of potential there. There was earlier a question around, how do you build into Casey's models, how do you build in consumer preference into the model in terms of what's important and what's not? And certainly being able to sort of drive treatment decisions is an important foundational aspect of the recovery movement, right? And I think having more access to knowledge, more access to interventions that people can try on their own, and really leaving the sort of contact with the healthcare providers as being more of sort of expert consultation, right, is just a logical extension of our current sort of case management model, where we deliver psychiatric services in our buildings, and we also have case managers who go out and about and try to connect people with other resources available in the community. And I think one under-tapped resource is those sort of technological resources.
Deb, did you find anybody, following up on that, did you find anybody starting to do what is being done all over the third world, which is community health workers, taking people who are not trained in nursing or medicine, but are nice people, friendly people, well-respected people, giving them some training, and in this case, a tablet, sending them into people's homes or where they live or where they work. Are people doing that?
Absolutely, and I think many folks in the room would be familiar with a peer model. A lot of programs were able to, at low cost, expand their capacity to do things like run wellness groups and do fairs and do a lot of community outreach to get into other sort of, through snowball networking and other ways that they might have friends or family in the community to sort of bring them into the fold. I certainly heard a number of examples anecdotally about couples coming in for wellness services or classes where one member of a consumer community might have been enrolled in services, but then, they wanted to eat more healthily. They were going to a nutrition class. They started going to a walking group, and then they would bring their spouse or their partner, who would bring a friend, and it would sort of grow from there. So certainly a lot of work in that regard. And then again, a number of the programs, and for folks who are familiar with sort of the development and success of new healthcare initiatives, time and time again, you hear about having a champion. And very often the champions that we would hear about from these programs would be, maybe there's a nurse or nurse care manager or somebody who is part of the program and knows the bridges, the hangouts, the abandoned buildings where consumers tend to be, and they know everybody by name, and those are the folks who keep programs going. So on the one hand, and many times they bring with them mobile, they can bring resources, they can bring treatment and monitoring equipment. If they know somebody who's homeless is diabetic, they can go and bring a blood pressure or a glucose monitor or something with them. And it very often, at least in my experience and what I've seen, is a combination of having mobile resources where you can go to where folks are, and being able to use staff at the top of their license. So if you're a peer, doing the best you can with your peer staff because they're affordable, but also not in absence of the human component. So from what I've seen at this stage, and maybe it'll look different moving forward, it's usually a hybrid of mobile stuff and agile people.
Melissa, what would you?
Well, I actually wanted to add about efficiency on something that Wes said, which was, there's a gap in the psychiatrists or behavioral health professionals' days. I'm working with a clinic network where 30 to 40% of the population leaves with a paper referral and a 3 to 4 month wait time to get an appointment with a psychiatrist. And the psychiatrist might be 4 blocks away. And that psychiatrist has an 80% no-show rate. So it's one of the few areas of medicine you can't double book an appointment. So that underutilized time, how can we better spend that time? Doing paperwork, or can we see if someone needs help right then? So now instead of giving the paper referral out, one thing we're trying to do also is make systems more efficient. So then that time can be spent seeing if that person 4 blocks away is getting a paper referral. Instead, at that primary care clinic, let's digitally co-locate them, put the patient in an empty room with a tablet, and connect them for, maybe it doesn't reach the 37-minute CPT code minimum for Medicaid, but maybe it's 20 minutes, and that time could be better spent with a patient than not being spent at all, and we lose less people in the system that way. So a little tangential to what you said, but.
No, it's interesting. I mean, it's also sort of notable that 4 blocks in New York is probably a similar model to a colleague of mine in Texas, rural Texas, where they have sort of video psychiatry from one county to another, because they cross 40 counties in their mental health network and don't have the providers there. It's probably a similar gap in New York. Just
we take cows 4 blocks. 4 blocks take a taxi.
Right. But I think the other piece that we've talked about a little bit today that's notable along that is that when you realize these steps towards integrating technology into treatment, design is really important, right? And it really sounds like you've brought the sort of tech industry's attention to detail with that and making sure that the user experience is really simplified. I mean, I think that's what feels a little clunky right now in behavioral health care, in community mental health, is that we have all this business intelligence, these sort of alerts, and it feels like the managers and the clinicians are sort of drowning in data, and reminders, and it's hard to sift through what's important and what can be ignored and what's sort of a usual pattern, and then we provide consumers with a consumer portal and online access to educational materials, but it's hard to sift through what would be interesting to me right now, or what should I pay attention to. And when the experience is disappointing like that, I think people tend to just stop looking at it.
So on that, I think contextually aware applications are the future beyond set programs of even CBT, which are successful. But if I can tell where someone is in a location and also have some background on that patient's history and previous appointments, I can just make my system can make a better informed decision on care when they need it. Even if it's a push notification, do you need to see someone now? So I just completely agree with you. That,
There's a very interesting part of this argument, and it does become an argument very quickly, I've found, and that is between personalized health. There's one view, which is that is me sitting down with my therapist. And as somebody who has sat down with his therapist on regular occasions, I always enjoyed that, and usually enjoyed it, and got a good deal out of it. Or sit down with my GP. When we talk about personalized health, we're talking about something quite different. We're talking about really understanding you as an individual, your genetic structure, your history, the likelihood of your preferences. I mean, if you get personalized that way and then say, okay, for all 60+ year white males with these genetic features and this history, this is probably what he needs to do. And by the way, he's already told us he wants to do. That's real personalized care. And contextualized the way you're talking about, I think it allows us to have the real experts that those of you who have given your lives to this field to then work on top of that should make you incredibly effective, as opposed to fighting for a kind of an old model where personalization just means you're there in person.
I
Can I ask a
wanna-
question?
Oh, sorry.
Yeah.
I just want to, so one thing so I'm a smoking researcher by training, tobacco researcher by training, and so part of the grants program that we worked on, we were really encouraging providers to use breath carbon monoxide. So it's just like a breathalyzer, you know, you blow in a tube and it tells you whether or not you're drunk. Well, you blow in a tube and it tells you whether or not you've recently had tobacco exposure. And if you're cutting down on smoking, then you know, the number drops lower on the device, and that's, you know, classic biofeedback. It's reinforcement that your consumers are moving in the right direction with a behavior that's really hard to change, and that we know many consumers are very interested in changing. It's expensive, it's stigmatizing, and boy, did we have a heck of a time getting providers to use the goofy little breath CO monitor every time they had a client or consumer in the room who was working on smoking. So to me, I mean, that is technology that's not complicated, and it's handheld, and it's easy to use, and it's cheap. It's, you know, $500 for the
Why
clinic
was
to
that?
have it. This is now.
You know, why was that?
Oh, why was it? So, you know, we heard that it was, providers didn't quite understand what to do with the information. They didn't really see how it was relevant. It was one extra thing that an overburdened primary care provider needed to do. So I just want to raise the flag. On the one hand, you know, all the possibilities of technology I think are phenomenal. On the other hand, as folks who are doing the interfacing or maybe are doing the delivery of community behavioral health provision, we have work to do, again, for this translation piece. And so I'm very interested in thoughts from the crowd about how to shift the culture, how to make these kinds of tools more accessible and more of interest to providers, because on the one, they might be, and on the other hand, they may not be.
Mm-hmm. You know, it's interesting. I mean, when I was practicing psychology, you know, and doing therapy, I was doing it in the pencil and paper era of, you know, writing down. I gave that up in order to implement an electronic health record and haven't gone back. And so I feel like I have this perspective of like, well, I don't know that I would do that, right? Like, and I think the opportunity really is to catch people at the beginning of their career, right? Start implementing these technological solutions in graduate programs and have people arrive into the workforce and drive the change sort of organically from the ground up rather than take a top-down, here's what SAMHSA thinks kind of approach that is just bound to run into resistance as you hit these different clinical groups.
You are not going to convince, my experience at least, is trying to convince a doctor who's older than 40 that they should learn about nutrition is impossible. Convincing them they should really worry about healthcare, about mental health when they're a surgeon is not going to happen. So let's throw it open to the group. And